recording, so at least if anyone else who's got an issue. So yes, there are differences. We'll just get Divya to come on as well. But yes, they can be differences about what you expected, and the tricky part is everyone's idea about what those demands are can be a bit different because all trainees are different. But there is a kind of an idea, and the best way is to perhaps go through certain things on your ePortfolio. So I'll share my screen for a second. And like I said, I want this to be quite interactive. So you got questions, even if you think they might sound a bit silly, now's the time to ask them, basically, okay? So for most of you, if you remember, your ePortfolio will have a section called Summary of Progress. And you've got your IMT ARCP decision here, which we might go through too. So I think it's worth keeping those things in mind. But the Summary of Progress is quite helpful because it kind of already starts outlining that checklist of the things you kind of need for IMT2. For example, you still got to have your educational supervisor report. And particularly, it's to cover the training since the last ARCP. So whatever gaps you had that the ARCP report last year mentioned, that's a good thing to start looking at for this year. For example, if your ARCP reported that you had very few CBDs and you need to work on that, that's already something you've got to start picking up for this year. So I guess rule number one, if you haven't done it already for particularly IMT2 trainees, start looking at your old ARCP and educational supervisor report to find out what deficiencies or gaps there were that you were meant to work on for this year. So that's rule number one. Okay. Any questions about that? If you can't use your microphone, you can text on the group too. So either way is fine with me. So moving on, after you've got your ARCPs, probably part of it will be seeing whether your ePortfolio capabilities in practice, the SIPs, or really meeting expectations. Because as you remember, you have to record your self ratings for this one. And then after that, your educational supervisor will also record a rating for each generic SIP. So obviously, ideally, for those 6 SIPs, you need to be meeting expectations. If you got some that are below expectations, you got to work on those. So that's the next part that you want to start seeing. It's essentially just like you're checking your health. This meeting today is your first, think of it as your first checkup. But let's just say you had a chronic condition, something, you need another checkup in a month's time to see that your blood test results and everything were the same and improving. So same thing here. You want to see that your portfolio is in a healthy condition. As you can see, then you've got the other SIPs, the clinical capabilities in competition in practice, where you want to have expected levels achieved for critical progression at IMT2. So basically, all these areas, you need to make sure you've done your self-rating and you really by towards the middle half of the year, your educational supervisor should be giving you what we call the entrustment level, which is saying you are entrusted to hopefully run a lot of these things independently. Moving on from that, don't forget some of the simple stuff. You need your MCR reports every year. So you may have done them last year, but you need at least 3 of them by your consultant this year. You do not want to be doing it at the last minute. So I guess one other rule to tell you guys is, just like with last year, you got to plan ahead. But remember, there's a lot more riding on this year because you can't just say at May 2022, oh crap, I've got these things to be done. They want to see that you're organized to be getting them ready quite early on, because the problem will be is they may not be as forgiving with last minute entries. They do not look, there's a lot more writing because they are kind of to a degree almost trying to say, oh, you're a registrar ready. So these things you can't take lightly. You want to be organized and start doing your MCR slowly over time rather than trying to rush them at the end of the year. Same goes with MSFs. Don't leave it to last minute. You know, some of you might be saying, "Oh, isn't it a bit early to start in IMT2?" Not really. You need these things now, and actually, the more you do now, the less you need to worry about later on. So start getting those MSF if you can. Don't forget to get the minimum number of 4 ACATs, which have to be by consultants, because some of you have them done by registrars. You must remember they don't count. Each ACAT, another thing people forget, it has to be a minimum of 5 cases. All right. The same with CBDs. There's a minimum number of 4 to be carried out by consultants. So it's just making sure you're keeping track of these things you're doing. This is a big one for some people, and essentially, you know, it's a big pressure for you guys, but remember that there is this target of completing MRCP, which I think is a lot for you guys to think of, especially PACES, which is for, you know, IMT1, you're thinking about MRCP part 1, that's fine, but there's a lot of planning involved the other few parts of MRCP, and I think that's a big ask, particularly PACES, and I might just stop here to discuss about that. Has everyone got a, sorry, that's the wrong screen. Has everyone got a good idea what you need for your MRCP? Do you feel like you're on track, or do you think you're gonna have a problem? Serena, you got your hands up.
Yeah, I just wanted to go back to the multi-consultant reports and the ACAT subject, because obviously we spend a good amount of our time on call. So we do end up working with a lot of the same consultants we worked with last year. So does it matter if, you know, the same consultant
No.
signs an ACAT or an
As long as
MCR?
it's not your, as long as I think it's there's a variety, it can still be the same consultants, because you are still working with the same consultants this year anyway. So no, that's not a problem.
Okay. And I mean, what are the actual practical outcomes in terms of ARCP if one is to only have part 1 by the end of IMT2? Do you know?
I can't say I know for sure, but I can give you a rough idea based on, because obviously for a lot of people, IMT3 is going to be a new thing, even for a lot of ARCP panelists. But most likely, one of the what they are to decide is, can you achieve your paces in IMT3? So if you've literally not done any part 1, part 2, part 3, one of the potential outcomes, depending, is that you need more time. So they may say you can't progress to IMT3 yet. You need an extension of your time as IMT2, particularly if you, I would say, if you haven't had any MRCP. Whether if you just pass part 1, that's a problem. I think it depends on different factors. For example, if you've got MRCP part 2 date already in the bag by, say, May, they might, you know, that might be different. But say it's someone who's not even studied for MRCP part 2 and hasn't got a date, then yes, they may suggest you need more time in training. So that's one possibility based on what we would have done as a panelist for someone in core medical training. I hope that answers your question to a degree. Yasser, you've got a question too.
Yeah. Hi, Dr. Wong. Yeah, sorry, just regarding the paces. Is it really a must to do the paces before progressing to IMT3, or we can do the paces in IMT3?
So that's a good question. On the ePortfolio is suggesting that, but unless I've mistaken, and give me a second, I'm just going to have a look whether I can find what your IMT panel. Did any of you attend the latest induction virtual Teams meeting? Unfortunately, I wasn't there at the time, but I wonder if anyone here was at the virtual meeting that they had recently. Don't worry if you haven't. So I'm just having a quick look. Monibus here as well, that's fine. So remember what you were saying about the outcomes, what they could be like, Serena. So these, just like they say, they can have these 10 outcome ones, 10.1. So it's worth knowing, like you said, what they are. But a lot of times about time. I'm just having a look here about your MRCP requirement. Well, my understanding is it should be MRCP part 1 and part 2 at the minimum. But I may have to get back to you, Yasser, because I may not have the right answer for you right now unless someone else can answer that for me. The goalposts changed a bit because COVID adjusted some of our targets. And I do think it isn't completely 100% mandatory. You must have paces, but it would be more ideal for you to have it, or at least be sitting it soon, basically, is my take on it. I'm just trying to see if, have you guys heard anything different about that? There we go. So if you see on paper, that's what they're asking. There may be some leeway in IMT3. They say that you pass it there, but I think personally for me, if from being practical, you should try to work on the premise that you've got to try to pass it. Okay. It's not set in stone, but I think the people who say I might be okay without it, it just gives you that psychological problem that you might not try to push for it. Equally, on the other side, I also don't want you to feel, oh my God, I'm screwed. I can't get all this done. There's obviously some leverage when they discuss it at panelists, and say we get another massive COVID issue this year, or there's a lot of disruption, they would take these things into account. So the panel is not like cold-hearted in a way. But personally, for me, from a practical side, for you as developing doctors, having working 4 paces is a good thing, because you train, you discipline yourself to work for the exam, and actually become, and anyone who's done paces or is sitting for paces, they do grow as senior trainees, because you focus yourself on how to examine, how to present as a registrar. So I think, Yasser, the practical perspective is on paper, it is still saying that you should be ideally passing MRCP by IMT2. Personally, though, I know it feels like a big ask. I try to train my trainees to try to work towards that goal anyway. Does that make sense a bit?
Yeah, thank you.
Yes,
I mean,
thank you.
I hope so. It will be a tough one, but we'll try to.
I think one factor we got to put into account, actually, if we are saying we got to sit and start acting like we're going to pass paces for this year, is we probably need to make your paces training more robust. Because we left all that last year. It was all about part 1, sorting out COVID. But this year, I think actually what we probably have to do as an IMT group is trying to structure our paces training so it fits your purposes. You see, 4 years ago when I was a trainee, we all stayed back at 6 to have a registrar or consultant go through a paces case. That seems to have changed. From what I'm hearing from the consultants, a lot more trainees prefer to try to do it ad hoc during the day rather than at the evening. So we've got to work out what works best for you guys. And it may be as an IMT group, we have to see how it goes. Dr. Christofferson used to train for PACES and do the PACES courses. So she's happy to help, and I'm probably going to add her onto the IMT WhatsApp group. If you don't know already, I'm not sure if eSpawn's the same, but we have a PACES list, I believe, here in Conquest. So you can add these cases on. And I think that's what we're going to start doing, basically, so that we can start highlighting cases that we can bring you to see. Does anyone else has a question about MRCP and PACES? Now's the time to ask, so please don't feel afraid to ask, really, or even put the question on the group. So moving on a little bit after the MRCP, some of the other things are very basic in the sense you need your ALS. So don't forget that. That's because it's harder to get on the courses sometimes. So make sure that that doesn't expire. Or if it's coming close to expiring, start planning ahead for your next one. Actually, a lot of trainees, when they go for the ARCP for IMT2 or CT2, one thing is quite interesting is they've done everything else, but they totally forgot about ALS just because, it's one of those things you take for granted that you've already okay. And then you look at the expiry date and it's not. And everything else is great. So the panel would have given an outcome, a great outcome, if it wasn't for the ALS. So don't lose track of that. It's very easy to forget. QI projects, for IMT1 is quite easy. You just need to be engaged in one. You didn't have to complete it, but you're going to have to show full completion of a QI pad. So this is where you really have to pull out the guns and finish your QIP, get the assessment, because it's no more about engagement. It's you got to finish it off. Outpatients is a big thing. So there's talk about, well, they put the minimum, it has to be 20 clinics, is whether a lot of people can achieve that, and would that be a strict criteria for passing ARCP? So some of the talk is that they're not going to say, yes, we will fail you if you don't have enough clinics. But the truth is, I would say you should still behave as though you need that to pass, because number one, a good registrar has experience of clinics. So if you put it mentally that, oh, they're not going to be so hard on me, you'd be surprised. ARCP panels differ depending on the candidate and who's on the panel. Sometimes they can be very strict as well. And the last thing you want to do is fall at the final hurdle because they think you haven't worked enough for your clinic. So if you got opportunity for clinics in the specialty you're doing, use them. Don't leave them alone just saying, oh, I don't feel it today that I should do clinic. Or if your department is not giving enough clinics, you can let me know whether there's room to tell the consultants offer more clinics, or you can do clinics in other specialties. For example, in gastro, I'm happy to supervise IMTs for clinic. I do mine mainly at Conquest, but a lot of the clinics are nowadays by telephone. So for IMT trainees at Eastbourne, as long as you've got a consultant, you can call, like say we're doing the clinics in different rooms, but by telephone, but you've got me by telephone. I'm happy to run that clinic with you. So the key is you should still behave as though you need those 20 clinics to pass IMT2, because number one, it will force you to upgrade your skills and your knowledge. And at least, even if they were quite lenient, you've done the what you need to pass the year, because you don't want it to be at the wire that everything else is okay, but then they look at your one outpatient attendance and say this person is taking us for a bit of ride. They've only done 5 clinics, and yes, it's not the set rule. They need 20, but we don't think you've been doing enough. Do you see what I mean? Any questions about outpatient clinics? Anyone having problems doing outpatient clinics at the moment?
I have a question. Will it matter if the whole amount of the clinics is under one specialty only? Because I personally have not been offered SHO cardiology clinics, and it's really hard enough for me to attend clinics because of the rota, because I'm either on call or short staffing on the ward. So will it matter that it all belongs to one specialty?
On paper, it doesn't seem to be. I think it depends on how ego-eyed the panelist is. If you could have a panelist saying there's too much of gastro, so it's nice to have some variety. But if they had to sign you off purely on the basis of your outpatients, if you got 20, theoretically they shouldn't say that you can't. But personally, I think it's better for you to have a breadth of different outpatient experience, because gastro outpatients are slightly different from a different specialty. So it is good to get some in the specialty you're in. And like I said, if we're still struggling with that, we might want to see whether we can get the consultants to offer you more with that. You shouldn't be afraid to ask. But officially, they shouldn't be able to fail you on the basis that it's all gastro clinics, as long as you've done the clinics. Does that make sense?
Thank you.
Anyone else have a question about clinics?
Hi, Dr. Fong. Is there any minimum number of patients that we have to be seen in a clinic? Because I'm in geriatrics now. Sometimes I used to get like only one patient or something like that, because assessment would be long.
It's quite interesting. They don't seem to have set the rule, unless anyone's heard differently. Let me just see if there's anywhere else that says anything about the minimum number. I was struggling trying to get a clear answer about that as well, actually, I must be honest with you. Let's have a look. So it doesn't say so. Okay. It just says a minimum of 20 and 80 outpatient clinics in total. So 20 clinics in IMT3 and 80 altogether. So the bottom line is do the math, because you clearly need at least minimum 20 in each year. So most of you got away scot-free last year. and you need at least 20 this IMT2. But if you really want to make it so that they don't think you're taking the mickey, trying to do a bit more than 20 this year, if possible, is really a good idea. To be safe, I would definitely say one patient in a clinic is probably not very good. Minimum for me, I would say that I think you've done a decent clinic is 4 to 5. That's why I've tried to put 5 or 6 so you can in IMT clinics that you do with me, because it then just evens out basically. So they might not necessarily look at how many patients per clinic, but if they see your total number of outpatient patients you've seen is fairly decent, they divide it by the number of clinics and they might say on average you're seeing about 4 per clinic. That's all right.
Okay.
So it doesn't look officially, but I might check that one. How many is in the clinic? But I would say, I think they're probably going to say, what's a reasonable number? I think 3 to 4 minimum.
Okay then. Okay then, Dr. Fong. Yeah, thank you.
Cool. Acute selected take. This is important. So basically, what you've got to start looking is, I always suggest to my patients, you've got to start keeping a log. It says here a total of 500 patients by the end of internal medicine training. At least 100 in IMT2. So really, you will see this many patients, but the main thing that most people fall out in is they're not taking a log of this. So if the panel wants to be quite picky, they'll say, well, where's the proof? So you have to show it in different ways. You can put an anonymized log or Excel on your library to say this many patients seen. And yes, you could say to some people you're making it up, but it's showing the proof rather, because you definitely will see that many patients throughout all the medical takes you do. It's just trying to get that recorded to some degree. So apart from that, critical care, for most of you, you have to show evidence of completion of a minimum of 10 weeks in critical care, which for you guys should already be incorporated in most of your rotations. If not in IMT1, it will be in IMT2. Has anyone got any problems with their ICU rotation so far? Anyone? Hands up or just say something. Yeah. Okay. Geriatric medicine. Sorry, did someone say something? No. Geriatric medicine.
I just had, sorry, doctor, I just had a tiny comment about the ITU rotation. I mean, it was quite good as a good experience. There were just two things about it. The first thing is that the on-calls were done as acute medical on-calls, so you would actually miss a lot of the ITU days rather than doing being incorporated as an ITU on-call. And the second thing, there was no structured like a teaching program or induction program of the what you should be doing. I mean, literally, I had to search for online courses to be able to understand the whole. I mean, like the new medications, things to be done. So there was really no proper, good structured way of approaching the ITU as a. And I'll be honest, I mean, the CT trainees from ITU coming from HCS or coming from other specialties, they are more advanced than us, given the fact that they had to do some sort of trust grade years in ITU before they get accepted. So a CT1 from an ITU would be completely different from a CT1 coming from medicine. And there was no structural teaching as well. I mean, I'll be honest, I had to do the hard work, going home every day, stressing about what to do, what to prepare for the cases. So I would say lack of induction for ITU was a big thing. I mean, the staff they are actually helpful, they are good, but there was no proper structure. You feel like you're an add-on or some sort of someone passing by. That's the issue, and you want to feel that there's a teaching. You're going to come out with an outcome. Things need to be fulfilled. All these things. I didn't feel it was really that good in ITU. Overall, I managed to do. I mean, I get competencies in central lines and arterial lines. I've learned a lot of stuff. Maybe the timing wasn't that good because of COVID, but generally speaking, I would say ITU rotation, we could maximize the benefits from it if there has been a good structured program of how to approach it, really.
That's really good feedback, Yasser. Thank you very much for that. I think you're right. It's important to have a structure and induction. So I think as with all new changes in portfolio, probably there wasn't enough work put into that. So actually, I think that's a good place to start actually, and whether we could involve you to that too. So the anesthetist that's involved with ITU rotations at Conquest is Alistair Lowe. So I'll feed back to him. But I think actually what would be really good, Yasser, is if you send me an email with those thoughts that you told me, and Serena agrees as well. If both you and Serena can email me with a bit of suggestions like structure, induction, I can forward it to Alistair Lowe saying, how can we work on this? Can we have a teaching? Did you guys have a regular ITU teaching session at all or nothing like that?
No, there was nothing like this at all.
We got to work on that.
No, it was
so
always bedside teaching, but the whole experience was teaching because we were supernumerary last year. I think so we were just floating essentially.
That's really good feedback. So if you can send me an email about that, I can forward to Alistair, see if we can refine that. Is anyone else due to start the ITU rotation next in December? Hands up if anyone's due to do that.
I think Kitech is in ITU at the moment.
Okay. It's just for anyone starting ITU in December, it's like you say, it might be good that closer to the time you touch base with your anesthetic supervisor there. So we make sure you have an induction and a structure, because it's always easier to start it before you start the rotation. So you got plan rather than to remind them at the rotation. But I think that's really good feedback. So I'm very glad you told me about that. The second point about on calls is a bit tricky. I think at the moment we don't have the staffing to completely alleviate you not doing the on-call for ITU, but it's something we are trying to move to. So there is Alistair is also trying to push for that. And I think over time that might be something for the future. But it is difficult. So I agree you. I wish you didn't have to do medical on calls at the time, but at the moment the system doesn't support it easily. But we are moving away from it, I think, over the next few years. But I think having a structure and good induction probably is the key to the teaching in that area. Geriatric medicines, most of you have done more than you want of geriatrics. So I think it would be very unlikely that you have a problem with this area. Has anyone got a problem with geriatrics?
No, it's quite good. It just it says here that the MCR. Oh, sorry, MCR by a geriatrician. So, sorry, I thought it's a naked. Sorry about this. That's fine. Sorry.
Okay. I mean, actually answering your question, Serena, so it sounds like one of your MCRs should be by a geriatrician. So that's the only additional thing you should say. I mean, it can still be the same consultants from last year, but one of them should be a geriatrician. Practical procedures, simulation training. Who's not been on a simulation training program? Or more likely, hands up if you've been on the simulation training. So no one. Oh, okay. So Amina, Yasser, Serena's on. So Ketsia has been. Okay, so quite a few of our side. And that was the one at Eastbourne, wasn't it, guys?
Yes. It was for one.
Yeah. And
for those of you IMT trainees who haven't gone on one, obviously, you need to go on one as early as possible in IMT year one. So if you are struggling with a simulation training session, you need to let them know. They're mainly run by Sam Pentaclan in Eastbourne, so it's definitely something you need to do. Amina, you got your hands up. I don't know if that was because of the question or whether you got something to say.
No, sorry, it's still out. No, I just wanted to say that I have done the simulation training at Eastbourne. Let me just.
Was it fairly easy to get onto the simulation training registration?
Yeah, for me, it was not that bad. They just sent us an email and we just applied. It was simple. It was actually pretty easy.
How did you find out about it? Was it through the trust email or did you find out through a different way?
I got it through trust email.
Okay, that's good. Okay, that's fine. So yes, definitely sign up for that. Teaching attendance, this has been sometimes a bit tricky for some people. So 50 hours teaching attendance include minimum of 20 hours IMT teaching recognized to CPD and approved by local office. So a big part of it is Anita does keep a log. But if you're not sure how much you're achieving, I suppose don't leave it until the last minute, like in May 2022, to ask Anita, how many hours have I logged on? Anita, I'm assuming you keep track of this every month anyway.
Yes, that's why I log on, just to make sure. Teams a bit harder, so I'm noting people that have joined my teams or in the room.
So I think it's important for you guys to keep a log and check regularly each month how much you're accruing, rather than try to catch up later on, because it's quite hard. So part of it is, if you're not sure how many hours you logged on here and you want to be sure how accurate it is, you could probably let Anita know. Obviously, don't do it all in one go. Anita's going to have quite a lot of emails, but if you want to check in with her, that's probably a good idea. Is that going to be okay with you, Anita?
Yes, no problem.
All right. And practical procedural skills. This is one that you've really got to try to get the right evidence. Like you see, some of them we know it's impossible to do in real life to a degree. So these have to be skill lab certified. Vast majority of them actually can be. So don't forget about these and trying to get them done. They're so much harder to do when you only got a few weeks or a month left before the RCP. And that, in a nutshell, on top of a few other factors, is probably what you need to keep a track on for IMT2. So I wouldn't actually say it's rocket science. It's not totally different, but you have to realize now it is on the wire. You have to get this done unless there's a particularly big reason. Amina, you got your hands up. Go ahead.
Yeah, Dr. Fong, I have actually a question about our study leave. I think in 6 months we have like 7.50 days, if I'm not wrong. So I found it really hard to manage within this like study leave because you know we have like KSS training day, which takes almost 4 hours. It normally happens every month, and we have some Pan London teaching as well, which we try to attend. And example, like I will give my paces, so I need to do a paces coaching, so I need at least 2 to 3 days for that 2 to 3 days study leave for attending a coaching like that. And some of us are actually trying to improve their portfolio. It wants to apply for like a group B specialties this year or maybe next year, so they're trying to do some courses and stuff that will look good on their portfolio. So what's the rule for this study leave? If, for example, someone needs more than 7 days study leave in a 6-month period of time of rotation, then do we have any alternative? Like, can we take some study leave from the next rotation? Or if something is spared on the previous rotation, can we just borrow them from there or something like that?
It's a good point. Nora has just written here 15 days each 6 months, actually. So it might be you've got more than you think. Anita, I don't know if you know anything more about this, actually.
No, I don't have much involvement in Health Roster. I can try and find out.
Hello.
Nora is suggesting it's 15 days each every 6 months. Oh, go on, Yasser.
My understanding is it's 10 days per rotation, per 4-month rotation. So that would be 15 if you're doing 6-month rotations.
So you got another 7 days, Amina.
Because I don't know, like whenever I try to apply for it, like says the total days is 7.50. Anyway, I can double check with my rota coordinator and I can liaise with them. But thank you for the information. Thanks.
No worries. Kate, thanks for that. Where did you find that information from? Is it in the IMT rough guide?
No, it's on the allocate where we normally apply for the study leave. Actually got it from there, but definitely I can double check with them. Like maybe I have found it wrong or something. But anyway, but thank you for the information. Thanks.
That's good to know, actually. You probably have more, and it is tricky. I agree, study leave. But I think if you got 15 days every 6 months, that should hopefully be a bit better. Yes, sir. I didn't answer. Didn't get your question earlier. What was it?
Yeah, sorry, just the question was regarding the DOPS. So, for example, if I'm already completed my DOPS in IMT1 by consultants, to do it independently, can I just keep a log of the procedures I do during the second year, or does it have to be also observed by a consultant? Because this will be very difficult.
If you've had your DOPS signed off as independent in your first year, your IMT1, I don't think you need to re-sign it off in IMT2. It's more for the ones you haven't had a competent sign-off. For example, in your procedures, if you had already skill lab certified for these back in IMT1, then it's fine. Your supervisor might have to just confirm it, but you don't have to have a second consultant to do that. But say you've had, let's say, paracentesis, you've not had someone sign you off, then you definitely obviously need it done. Is that answering your question?
Yeah, thank you.
Okay. Anything else, guys? So I hope what I've tried to do is give... Oh yes, go ahead.
I'm doing ACCS internal medicine, and I've just received about 10 days ago that I've been added to the new curriculum for internal medicine, which basically they're gonna extend my core training or the internal medicine training to 1 more year. That means that I'm going to have to be a CT4 next year in order to apply for ST4 either as a higher trainee. I just been added, and I was a bit confused. Has that happened already, or they were just they were still taking decisions? I have no idea, to be honest.
This is a tough one for me, Ahmed, because my remit is with IMT, so I'm not privy to the ACCS changes. So what I would say is I don't know who's in charge of that. Anita, do you happen to know who runs the ACCS part of things? Or
Dr. Vidler is the EM and ACCS lead for LFG,
So I think Helen Fiddler is probably who you have to check with, Ahmed, about how that works, Danny. Because I mean, technically you're part of the IMT group, but in terms of the governance and all that, it's probably separate, you see.
Yeah, that's all right. Okay, Dr. Helen Fiddler, no worries.
Danny Fiddler.
Danny Fiddler, sorry.
Oh,
so, yeah,
Dr. Danny for the emergency, A&E. Okay.
That's right. That's right.
No worries. Okay, thank you.
Nora's had a question. Can I confirm for ACATS we can do it on the ward and not just on the take, as some struggle to have 4 purely on the take? That is a good question. Let me just check. When you're in doubt, the key thing is actually to actually just look at the terminology when it's on the JRCT website, because it can be tricky. So I'm just gonna have a look what the category says for here. Yeah. So as you can see, it says designed for SLEs on acute medical tape may be on a ward round or covering a day's management of admissions and ward work. So the short answer is yes. Guys, hopefully that's a bit of a run through. What I think I'm going to do is every month or so, if you guys want to, I'm happy to do these mini health checkups for your portfolio to give you a bit of a reminder and see what problems you all have. Or do you guys prefer that, or do you prefer a different system or anything? That's fine. So I hope that just gives you a little bit more of an overview. I'm sure for a lot of you, there are little gaps here and there that you need to work on. I want you to know that if for Conquest, you're more than happy to approach me, and I think it's still your let me think who's the college tutor at Eastbourne again. Sorry, Anita, Dr. I don't know what's going on with my dementia. Dr. VC obviously covers Eastbourne side, but when we have these sessions, I'm open to questions from both ends, basically. So good luck and all the best. And if you need anything, I'm here as well. Take care.
Thank you.
Thank you very much. I missed the first part of the session, so it's been recorded, has it?
That's right. It's recorded actually, so not to worry. So there'll be a record on this group actually, so you can download it if you want.
Oh, brilliant. Thank you.
No worries.
Thank you.